we shall go on to our next speaker, Dr. PRITI Uday, and who's going to be talking on my ideal surgical candidate. And she's a very leading oculoplasty surgeon from Chennai, very smart young lady with a huge potential and versatility behind that pretty face. And let's go on to hearing from her.
Thank you, ma'am. Good evening to all of you. And thank you, Dr. Chitra and ARC for this wonderful webinar and this opportunity. Now, I'm sure most of the patients would prefer my previous speakers who give Botox and fillers, because the moment you talk about surgery, you're not very popular with the patients. But we do know that there are certain scenarios where surgery does play an important role in these aesthetic patients. And that is what I will be telling you all today. What is my ideal surgical patient? So whenever we talk about success in surgery in periocular area, we know that it is a lot technique dependent, and it requires a lot of precision in this area compared to other parts of the face. Now, my ideal surgical patient would be a motivated patient with a very strong self-image, who is bothered by a particular physical characteristic that he or she would like to improve or change. So every word in this sentence is important. He has to be self-motivated. Usually I prefer that the patient comes to me with a complaint and I don't find that out for them. And they should identify what exactly bothers them. We can also help them to come out with the right answers during our consultation and then make a decision together. Usually these patients are in the age range of 30 to 70 years. Now, whenever you see the upper eyelid, when you have gross upper eyelid hooding, now this is an extreme patient that I have chosen, but I just want to tell you that if it is a gross upper eyelid hooding where you have a functional visual field problems, then surgery is the only option for these patients, because you may need tons of fillers for this kind of a face for you to, even improve the volume. And this kind of sagginess definitely needs surgery. So when you want to do volumetric changes in the fat prolapse that you see on the medial side, you have a superior sulcus defect, you have a lot of hooding, you have a broad droop. All these together you can do by surgery, and which does not need repetition also like fillers, and also you will need large volume of fillers, which is quite expensive. Now, when Adit was talking about 14 syringes of fillers, you must remember that each syringe is around 25,000, and you can imagine the bill that can go to the patient. But when you have these kind of patients who are actresses, whose look their profession demands the good look, and they are in their yesteryears and they are scared of surgery. So these kind of patients, you can give them a rejuvenation with Botox and fillers. And that is what I have done for this particular patient. But when you want to correct in a middle-aged lady like this, the hooding, the lower lid hollow, as well as some amount of fat prolapse, volumetric changes, I would choose surgery for this patient. Also, when you have Asian eyelid where you want to create a lid crease, it is a surgical indication. Or when you have a lash ptosis causing ocular irritation because of an excess of upper eyelid skin, you're going to choose blepharoplasty, and no amount of injectables will help you with that. Also, when you have ptosis associated with dermatochalasis, you have to have surgery, and also for lacrimal gland prolapse, like in this patient. If you evaluate the upper eyelid, you can see that she has bilateral lacrimal gland prolapse, she has hooding, she also has quite a lot of fat prolapse in the lower eyelid, and I would take this patient up for surgery and not venture into Botox and fillers. Now, when you have a lacrimal gland prolapse like this, you need to reposition the gland, and that is what is the technique here, and you cannot camouflage this very well with fillers, because in different positions of gaze, it will be appearing separate from the filler. Now, when you have a young patient like this who wants symmetry in the upper tarsal show, like she does not have a tarsal show on the right side but has it on the left side, you want to symmetrize it, you're going to do a skin alone excision on the right side to symmetrize, and again surgery is indicated. When you have a bulky eyelid like this, where the brow fat pad is prominent, and you also want to change the volume in the upper eyelid, I would use a brassiere suture along with excision, some amount of excision of orbicularis along with the skin to correct this kind of an eyelid. So this is the brassiere suture that I'm showing you, which is from the orbic to the periosteum, again through the orbic, which keeps the brow fat pad in position. And when I excise the orbic in these kind of patients, I prefer to do the superior orbic excision alone, so that you correct the volume to some extent, but also the function of the eyelid does not change significantly for these kind of patients. So this is what I do. I remove just the skin first, and then I remove just this upper part of the orbicularis that I'm showing here and entire lateral part of the orbicularis so that the patient also has some amount of brow elevation on the lateral side, which is desirable. Now, this is another patient who has a deflation of brow fat as well as excess of eyelid skin, and I would choose this patient for surgery. Now, as Adit also mentioned that when you have a mild grade of tear trough like this, you would prefer a filler, and that's what we have done for this patient. But another patient here who also has a grade 2 kind of a fat prolapse, you can camouflage it with filler, but she also has a lower lid retraction and scleral show, which is more prominent, and that needs correction. And so this is the result that you would expect with a filler. But I would say that surgery would give a better result for this kind of patient. Now, another patient who has gross fat prolapse, again, I would do a fat repositioning for her. And in this patient, we have no doubt that he needs surgery. And I would do a minimum excision along with a fat repositioning for the lower eyelid and also tighten the lower eyelid in that patient. Now, when we choose a surgical candidate, you should remember that the patient should not be on blood thinning agents. Now, the mistake that we do is many a times patients are using over-the-counter blood thinning agents like ginseng and omega-3 fish oil capsules or some vitamins, and this history is important before surgery. Also, generalized skin conditions. Many of these patients feel that history is not important because they are undergoing face surgery, but they can be on steroid long term, and that affects the quality of the skin. The fragility of the vessels is high. Post-op period is more tumultuous in these patients, and we must remember to ask this history to the patients. Another important history that I find is sinusitis, cold and cough. Like if they have a lot of allergies, these patients have fluid retention on the face, and you find that this fluid does not go off very easily post-operatively. And again, you have a difficult post-op period. So I like to treat these before the patient undergoes surgery. Also, all my blepharoplasty patients, I do a dry eye workup because we find that after blepharoplasty, their grittiness, foreign body sensation, the dry eye symptoms become worse, and therefore it's a good idea to do the evaluation and treat the dry eyes before the procedure. Also, history of glaucoma medications is important because many a times we put these patients on steroids post-op, and that can be
8 o'clock
to the patients who are already having glaucoma. Also, if they have a bleb, you would not prefer a posterior approach for their ptosis correction. And also the lid margin evaluation is important because they will again have ocular irritation, which will be aggravated in the post-op period. Of course, the patient shouldn't have had an intraocular or refractive surgery at least for a couple of months before the aesthetic procedure. And one important history that I find in most of my cosmetic patients, especially if they're actors who are in the media, very often they use ocular decongestants, especially during shooting, and you may miss underlying thyroid or superior limbic keratoconjunctivitis or allergies, and you must see these patients after discontinuing the decongestants for some time in order to unmask these ocular conditions. Also, when you advise surgery to the patient, we must discuss with them the downtime because it's not magic. It's not going to look totally normal in a week's time. And generally, I ask them not to have a social event at least for a couple of months after surgery. You can see this is the timeline that you see. A 1 week post-op patient usually has so much of ecchymosis and edema, which usually settles after 6 weeks. Also, you must discuss what kind of technique you're doing with these patients because if you have a lot of lateral hooding, your scar will extend a little laterally and which will be visible like this, and patient should be able to accept that in the post-op period. Now, these are the various timelines that you can see with many of the patients, like 1 week post-op, 2 weeks post-op, and 6 weeks to 8 weeks post-op. So that is the timeline that we require when we plan a surgery in these kind of patients. Also in Asian blepharoplasties, we are doing a very tight lid crease. In that case, sometimes you will have asymmetry in the lid height for the initial post-op period, which takes a long time, about 3 to 6 months to settle. And therefore, Asian blepharoplasty patients, I often tell them that we will require that kind of timeline. You can see here the edema in the pretarsal area lasts longer time in these patients compared to our non-Asian patients. Of course, we have all talked about red flags in our aesthetic practice. It has already been discussed by my previous speakers. Even for surgery, I think we should know when not to operate. And a patient in crisis who has lost a dear one or who has had a divorce recently, you must not take up these patients because they have unrealistic goals. The surgery is not going to change their situation, and we must wait till they overcome that crisis. Also, if patients like this want to become like this, it is not realistic. Even Milind can't transform me to that. And we must, have realistic expectations. If the patient is asking for a particular celebrity nose, it cannot be done. If they want to look absolutely normal after a very severe facial trauma, that's not realistic. Or if they want to look a couple of decades younger, that is also not realistic. So you must understand what the goals are for the patient. Also, some patients are impossible to treat. They go from doctor.
1 minute remaining, ma'am.
They want the answer to their question. And those are the patients you must avoid. And also patients who are obsessed with a very minor defect, because sometimes a very perfectionist patient can be a good patient for you as long as they understand that the surgical results may not be exactly what their goal is. Thank you for your patient hearing, and thanks for this wonderful opportunity.
Preeti, that was a wonderful talk and a very detailed talk. So do you think that when you do surgery, it can be combined with these fillers and all that, or surgery itself gets the end result?
So many a times we have hollows post-operatively where you can do touch-ups later, but I like to wait for at least a couple of months after surgery and then do all the touch-ups with the fillers. And I always tell the patients that after blepharoplasties, usually post-inflammatory hyperpigmentation will be there. They will have little bit dark circles. And if you wait for 2 or 3 months and then decide on the filler injections, it is a little better.
Dr. Shubhra, any question? Because we have 4 more speakers.
Not a question, but just a point here. I think this whole session was about who's the ideal candidate for injectables and surgery. I think there is no ideal candidate in the end. And also, I think you have to look onto the face totality and have a combination therapy. Some patients would require a stage 1 a surgery and may require stage 1 as injectables or vice versa. So I think a combination therapy is what works the best in totality. And I think all the speakers have covered the points beautifully and shown beautiful results at their ends.
Thank you. Thank you.